Today, I've been deputized by our great friend Dr. Sandeep Rane to help and give you in a simplistic manner what are the ABCD of treatment for trauma and accident patients. So, starting with my talk, I am Dr. Kishore Manek, orthopedic surgeon from Chembur, working in private practice for last 35 years. Today, I'll be able to rather help you in simplifying the management protocol at the site of accident, whether the accident takes place either at home or at your workplace or at your roadside, and either in a mass casualties or in a single casualty. Like trauma basically needs damage to the human tissue and human bones when there is an impact to the human body, either due to the fall from a flight of stairs or on a wet surface at home or at workplace, or involvement of a human body in a vehicular accident. Then this vehicular accident, the body can be having a what is called as penetrating trauma. They can be involved into blunt trauma. And when a person is traveling by a car and suddenly some vehicle, heavy vehicle, dashes the car, the person driving in the car, and can cause deceleration trauma, where person can have life-threatening injuries to the cervical spine, lumbar spine, upper limb, lower limb, and also head injury. These kind of casualties are also seen in major natural calamities, which can include tsunamis, which can include earthquakes, damages to the bridges either due to floods and natural calamities. So today we will understand what exactly is the role of a healthcare provider at the scene of accident when such major casualties take place in trauma. As the research shows, a lot of patients used to get lost because they couldn't be triaged to a center where the treatment could be instituted to them in a timely fashion. So a group of trauma surgeons came together and devised the guideline called as Advanced Trauma Life Support, which ensures the treatment at the site of accident within a one golden hour period, which was sort of researched and studied. And the conclusion came out of this report was that with the patient from the site of accident to the tertiary trauma care center is transported, the chances of losing the victim are minimized, improving the survival rate are better, and also reducing the complication in the near future are very good. So this golden hour was applied from the year 1985. As I know, I was working in Sion Hospital. And our main aim during that time with the team of orthopedic surgeons under Dr. Lars Gises, we used to imply this golden hour project into our hospital. And really, we found quite a few number of percentage of patients were reduced in the mortality rate. The Advanced Trauma Life Support System protocol is divided into four categories. First is the primary survey of the accident victim, then goes to resuscitation, then comes the secondary survey, and then comes the tertiary care. When we are looking at the primary survey, we have to look at the following principles of A, B, C, D, E. Correct? By A, we mean seeing that the person is having proper airway breathing. At the same time, we have to see that the patient doesn't have any cervical spine injury, which will further increase the chances of breathing issues. Second, breathing. What type of breathing the person should be having? If it's a normal breathing, whether it is laborious breathing, whether the breathing is due to some kind of a impalement injury to the chest. We have to look at the circulation, which could be one of the reasons where the accident victim loses blood and directly puts too much of pressure on the circulatory system. Third, we have to look at the D component, whether the person's neurological status is sound enough, whether he is moving or not. And E is indicate whether that person is exposed to any chemicals or chemical related burn injuries. During the resuscitation procedure, if we look at the patient's criticality, if the online healthcare worker considers or comes to a conclusion, no, this person needs cardiopulmonary resuscitation at the spot, then this can be instituted immediately. Once the primary care is done at the site of accident, the patient can be transferred to the nearest trauma healthcare center with direct one-to-one communication with the hospital authorities who manages the trauma ward in that particular hospital, where the patient again goes through all the necessary history taking, examination of the patient from head to toe to reassess the vital signs, to complete the neurological examination, and carry out certain lab tests which are very essential to know the criticality of the injury, and also x-rays along with certain specific investigations which may include CT scan of the affected part, maybe MRI if required. In the tertiary care, as we also know that all these injuries will be further looked into. Yeah, right, Nishi. When we say airway management, we have to see that if the person is having cervical spine injury, although the proper knowing which part of cervical spine, what fracture patient has got, will be seen and done only after an X-ray. But at the time of accident, we can always see whether the patient is getting cyanotic and whether the chest expansion is being clearly visible or not. So this is a picture where the chin lift and jaw thrust can be attempted, at the same time keeping in mind that you are not damaging further cervical spine injury. At times, if the need arises, patient can be undertaking endotracheal intubation. Tracheostomy can also be done in emergency situation, but I think that should be left to the trauma surgeon when the patient is transported to the tertiary care hospital. Of course, once the patient is transported, he should be transported on a board where the entire spine, upper limb, lower limb are well protected, and the cervical collar is given to the patient before he is taken to the tertiary care hospital. Breathing, as I already said, oxygenation is to be given, breathing is to be assessed, what type of breathing the patient is having, and whether the lung expansion is there or not. At the same time, circulation is to be seen. With the circulation, if the patient is likely to have a impaling injury or an open injury and he is losing a lot of blood, then definitely the patient's skin color will change. It will become much more paler. The pulse will drop down to maybe 30-40 per minute. There may be, or maybe, tachycardia, but the pulse will be a very low volume pulse. The patient BP can drop down to maybe unrecordable, or maybe 60-40 or 90-60. All these things will definitely, give you an alerted sign that this patient definitely is involved in a more critical scenario, where his level of consciousness also will go down if he has got head injury. Because of the loss of blood at the site of accident and associated chest spinal injury, there can be reduction of blood flow to the other important organs of the body, which can lead to low urine output. In that scenario, if we are able to assess the open injury, we can control the hemorrhage either by applying direct pressure with our hands or any kind of a cloth or a pneumatic device if it is available in the attending ambulance. Disability protocol to be seen, but I think this should be done more at the hospital level, where we have to check the alertness of the patient and whether he responds to the vocal stimuli. The response should be whether he is responding to the simple painful stimuli or a deep painful stimuli, or whether the patient is unresponsive. At the same time, After looking at all these parameters, we should also check the pupil size to know whether they are dilated and whether they are reflecting to light or not, which might give us an idea whether the patient has got any head injury or not. At times, it may so happen that while the time you are examining, patient may go into convulsion, may become decerebrate, indicating significant head injury or maybe a cervical spine injury. This is a complete when there is a exposure of the victim to chemical in a road traffic accident. As I already said earlier on, the body should be completely examined from head to toe. Nevertheless, we should not, strip our patient naked to know the exact nature of the injuries, right from tip of the toe, from tip of the hair to the toe. And also, we should turn the patient in prone position to assess the injury to the back side, which can always go unnoticed when the patient is fully clothed. All the hemorrhages, if it is there due to open injury, should be controlled and patient should be transported safely to the nearest trauma care center. As I've already said, the physical examination needs assessment of all the headings, head. Maxillofacial injuries should also be assessed to know whether patient has got any kind of breathing issues, whether there is any chest complaints. The cervical spine, again reiterating that it should be checked. Especially we should look more into the abdominal injury also, because sometimes it may so happen that the symptoms of the abdomen are very silent. Initially, you may not find any abdominal injury, but there are cases reported where spleen injuries, liver injuries, and renal system injuries are widely reported after the tertiary care has been instituted in the trauma care center. When we are suspecting any kind of pelvic injury, a simple test to be done at the site of accident is the pelvic compression test. If there is too much of compression at the pelvic region, which will definitely give you an indication that this person is having a major pelvic fracture. In that scenario, we should look at the perineal region to find if there's any kind of a damage to the perineal tissues. Looking at the rectum area, whether the rectum is damaged or not. And especially in women, we have to look at the vaginal injuries. The musculoskeletal system should be also examined and noted whether the person has got upper limb injuries, lower limb trauma, and whether he has got any foot injuries, which can sometimes go unnoticed. When the advanced trauma life support system was to be going on, another group of surgeons came up with a new strategy that it is better to simplify the trauma from SALT to START. Okay. Now, if the first trauma system to be implemented was START, simplifying it as simple triage and also rapid treatment. But all these things were further studied by the center of a trauma surgeon, and they analyzed that it is better to coin the word name as SALT, means sort out the person, whether that person is critical, assess the patient's ABCDE, and then accordingly take a decision which person at the time of accidents needs to be treated at the spot, early or delayed, or which person or traumatic incident or a patient which has got critical injury should be transferred immediately to the higher center. They came to a conclusion that the patient should be should be examined in the first 10 minutes and should be giving the following category of assessment. If the patient fell in the green category, then definitely the injury is likely to be very minimal. Hence, the treatment can be a little bit delayed as per the critical of the patient is not very conducive for immediate treatment. In the yellow category, the patient's treatment can be delayed, he can wait, but more important should be given to the red and blue zone where the person can trip over to blue instead of red. So these two categories should be given top priority at the time of vehicular accident or in a mass casualty, and they should be triaged to the higher center at the earliest possible time. I'll be sharing some few examples with the advent and a discussion of cervical spine injury. The picture on my left shows you injury to the cervical spine, which is basically a cervical spine dislocation. Here, first and foremost thing is, first of all, we must look at the head injury component. At the same time, as the X-ray depicts that there has to be an injury to the neurological system, which will cause quadriplegia. At the same time, along with this quadriplegia, some patients may have respiratory distress, and at the site of accident, immediate management would be put the patient into a collar and transportation to the nearest highest center. The picture on my right shows more like a spine injury. Again here, this is to be assessed only after all the protocols of ABCD are done at the time of the accident, and these investigations are done in the tertiary care under due control of a trauma and orthopedic surgeon. These are the further pictures which I am showing you how the spinal cord looks. In the middle picture, you'll see the entire spinal cord in the cervical spine is badly tinted, which will indicate that this patient definitely will land up with quadriplegia due to the severity of the injury at the time of the accident. The picture on the right shows damage to the lumbar spine, which is just at the level of D12L1 level. That is where the conus of our spinal cord ends. So this patient may also land up in what is called as paraplegia, along with bladder and bowel involvement. All these clinical examination of the spine injuries after due assessment at the site of trauma should be reassessed in a proper center, and further necessary investigation should be carried out and reassess, re you know charting your findings, and again going back to our ABCD to know that we have not missed anything in giving proper appropriate treatment which will increase the survivability of the patient. Similar, one more picture of the MRI picture of the cervical spine, just for indicative purposes. Injuries to the upper limb, chest injuries can involve clavicle injuries. Although these clavicle injuries seem to be very simple, but sometimes they can pierce the skin, can be converted from simple injuries to compound injuries. The clavicle sharp end can also impale the neurovascular structures, which can reduce the blood flow and compromise the neurological function of the affected arm. One more picture of the clavicles depicting how they can be really damaging the neurovascular structures. These are the injuries to the upper limb where humerus fracture has been depicted in this picture on the left hand side. This is the very severe critical comminuted fracture of the humerus. At the same time, on the right side, I have shown you how the elbow injuries can be a simple or a compound injury. In both these cases, again, neurovascular status has to be checked into, and second thing, whether these injuries simple or compound. Taking you further into the humerus fractures, these are the fractures of the humerus along with the wrist, and these fractures of the wrist joint, mind you, and let me tell you that this can go missed, especially the wrist fractures, because in the gist of managing patients for polytrauma, these small injuries of the wrist and the hand can always go missed. But as I said, in the tertiary care, the patient should be re-examined thoroughly from head to toe to see that we have not missed any fracture, and accordingly suitable investigation to be instituted to complete the treatment protocol. Pelvic injury, I have explained to you, is very severe injury where you lose lot of blood, and this has to be replenished with blood at the tertiary care center. At the primary center, I have already explained that pelvic compression test should be done. At the same time, if you see in this X-ray, you can see that the symphysis pubis is separated out. At the same time, both the hips are dislocated. So the severity of the injury in this particular patient is very, very critical. Patient will definitely lose a lot of blood. Sometimes you can experience open injuries in the perineal, vaginal area, and sometimes anal. This is one of another picture of the pelvis showing pelvic organ injuries. On the left hand side, these are the fractures of the femur, which again in a critical patient contributes to loss of blood to the tune of at least 800 cc to 1000 cc, and these patients sometimes have got complete open injuries which needs immediate cleaning, wound debridement, and dressing, at the same time triaging to a good nearby trauma center where the necessary treatment can be instituted. On the right side, we have shown the fractures of the tibia, which are very critical. They're comminuted, sometimes open. They need their due share of treatment. These are the again criticality of the femur fractures. The picture on the right I have shown basically to know that even in humerus femur fractures, we can encounter neurovascular injuries, and there are reported cases where when the femur fractures, the chances of femoral artery occlusion are very high, and lower limb going pulseless, which requires further management in terms of X-rays, MRIs, and especially angiography. And after the diagnosis that the vascular injury is confirmed, requisite treatment is to be instituted at the earliest possible time to save the limb of the affected person. This is the board which I want to show you, that how the person is transported, which has got a cervical collar and a cervical restraining board. At the same time, all the upper limb and lower limbs are well entrapped to this particular board. In the summary, I would say every healthcare personnel who is involved in the management of trauma patient at the time of accident should follow the protocols of ABCDE. This is very important because your assessment and direct communication with the trauma surgeon at the tertiary care hospital will keep on changing the treatment during the transportation. And it is very essential. Your assessment along with trauma surgeon will help us to give us better results, better treatment, improve the survival rate, reduce the complication, and also help us in giving better results and better rehabilitation in the future. My take home message to these people is stick to the ABCD of ATLS protocol, and I'm sure none of us will go wrong in assessing our critical ill patients and assessing at the site of accident and transferring them to the nearest healthcare center for better care and better treatment. Thank you so much for listening.